Okay, so my name is Farah Hanum and my supervisor is Dr. Nur Hafiza Hassan. I'll be presenting on basic of surgical nutrition. Moving on. These are the learning outcomes for basic of surgical nutrition. So first we need to identify the underlying mechanism and consequences of malnutrition in critically ill surgical patients. We use screening and assessment procedures to identify both patients with established malnutrition and those who are at risk, and describe basic nutritional and critical illness will affect these needs. Understand the various methods of delivering nutritional support and choosing the most appropriate options, and we will cover about enhanced recovery after surgery, the ERAS protocol. First, in terms of impact of malnutrition in hospitalized patients, malnutrition always goes unrecognized and untreated in many hospitalized patients. Hence, this can actually increase the complication rates, prolong hospital stays, and also readmission rates, and overall increases the cost of care. Hence, that is why we need to properly address the malnutrition in hospitalized patients. These are the basic nutritional requirements in a normal human being. Example, the energy required is about 30 to 40 kilocalorie per kg in a healthy adult. And so malnutrition is defined as a deficiency, excess, or imbalance in nutrient supplies to the body. Based on NICE guideline, malnutrition is defined using this criteria: BMI, one of the above meaning one of the below, BMI less than 18 kg per meter square, unintentional weight loss for more than 10% within the last 3 to 6 months, BMI less than 20 kilogram per meter square, and unintentional weight loss for more than 5% within last 3 to 6 months. So this is the stress response to surgical or trauma. This in regards with starvation or fasting. So during prolonged starving or fasting, a myriad of metabolic and hormonal changes will occur in response to that. So first, the surgical stress will stimulate the hypothalamus, causing sympathetic nervous system to be activated. And then when sympathetic nervous system is activated, it causes adrenal catecholamine release, and renin, angiotensin, aldosterone system will be activated, hence causing sodium and water retention. So in terms of when we fast, the insulin level will decrease and also increase glucagon level for gluconeogenesis. So in terms of screening, most commonly used screening tools in the UK is MAS, Malnutrition Universal Screening Tool. And based on history, we have to take detailed history, but it may be difficult in critical patient. What info we are getting is that regarding any weight loss, any GI losses, and from physical examination, we can appreciate any muscle wasting. And in terms of anthropometric and functional measure, one of the things is that we look into the BMI, triceps skin fold thickness, mid-arm circumference. However, in terms of this anthropometric, it required a trained practitioner. And then moving on, in terms of investigation, usually albumin is used as a marker of protein deficiency in chronic malnutrition. Next, we have to take the blood glucose, electrolyte, and renal profile, especially in terms of initiating the parenteral nutrition, which we will discuss after this. So this is the Malnutrition Universal Screening Tool, the MUST. So we have 5 steps altogether. First step, we have to calculate the BMI score of the patient, and then the weight loss score. And third one is to detect the acute disease effect score. Sorry, it's a bit blurry. And then the fourth one, we have to add on the 3 scores, and we will get based on that, meaning like score 0 is low risk, score 1 is medium risk, and score 2 or more is high risk. And the step 5 is management based on the scoring itself. Next, moving on to types of nutrition that we can give. We can give enteral nutrition. Enteral nutrition meaning supplementation of the oral intake based on dietetic review and adjustment of the meal plan to accommodate the patient's clinical condition. First, we have the nasogastric feeding. This is have 2 absolute contraindication and also relative contraindication. Absolute contraindication can be seen in mechanical bowel obstruction and in case of suspicious of ischemia bowel. and also patient refusal, related contraindication in cases of severe diarrhea or vomiting, circulatory shock, and also proximal small bowel fistula. In terms of the feeding protocol, usually we'll start off with 30 ml per hour, and the nasogastric tube is aspirated after 4 hours, and if the aspirate is less than 250 gastric fluid is aspirated, the feed can be increased to 65 ml per hour, and 4-hourly aspirate will continue. If repeated high aspirate, meaning more than 250, management will include reducing the feed rate, and if this still fails, we will introduce prokinetics to increase the gastrointestinal motility. The most commonly used is IV metoclopramide. Moving on, we have nasojejunal or nasoduodenal feeding. This is used in patients whom nasogastric route is contraindicated. Example, gastroparesis that fails response to prokinetics, or post-operative patients with upper gastrointestinal tract anastomosis. In terms of the feeding protocol, it is similar to the nasogastric tube. Next, we have the tube enterostomy. We have gastrotomy, jejunostomy, or duodenostomy. This is considered in patients expected to require prolonged nutritional support, meaning more than 4 weeks, or if access via oral or nasal route is not feasible in the short term, following complex elective abdominal surgery such as gastrectomy, or in major intra-ab injury. Moving on, just now we talked about enteral nutrition. Now it's parenteral nutrition, meaning it's used in oral and or enteral intake is unsafe or inadequate to meet the nutritional requirement of the patient. There is a non-functional or inaccessible or perforated gastrointestinal tract, and this feeding is usually supplied as total parenteral nutrition or TPN. So TPN is usually administered into a central vein, because if we give via peripheral parenteral nutrition, it has higher risk of thrombophlebitis. Second of all, peripheral parenteral nutrition acts as an alternative until central access is obtained. And third, peripheral parenteral nutrition does not provide equivalent nutrition replacement to TPN. For TPN monitoring, we have to monitor the glucose, because the carbohydrate component of TPN is supplied by glucose, hence hyperglycemia is common. Next, it requires daily renal profile and electrolyte, because this has risk of refeeding syndrome, meaning refeeding syndrome occurs following rapid reintroduction of carbohydrates, either enterally or parenterally. Hence, this refeeding syndrome is characterized by marked hypophosphatemia. Next, we have to monitor the fasting lipid profile, because TPN is presented as lipid emulsion. Hence, we have to monitor the triglyceride level. So, the last learning outcome is ERAS protocol. ERAS protocol, it is used for a package. It is acts as a package of care for a patient undergoing especially major elective op that aims to reduce the normal stress response to surgery, to reduce the complication and also speeds recovery in these patients. So pre-op, usually we will give pre-admission counseling, fluid and carbohydrate loading in terms of carbory. We advise for no prolonged fasting, no or selective bowel prep since in rectal CA. And in terms of intra-op, no drains, avoidance of salt and water overload. Hence, because we have learned just now, the activation of renin-angiotensin system will cause water and sodium retention. Maintenance of normothermia, this can be applied by body warmer, warm IV fluids. And post-op, we expect for no nasogastric tubes, avoidance of salt and water overload, early removal of catheter, early oral nutrition, and also early mobilization. So these are the example. This is the example of ERAS protocol used in colorectal department. As I mentioned just now, we have also covered it until the discharge plan itself. So we can see this in our ward mostly. Okay, next, in terms of question and answer, the four most common questions being asked is that, is albumin a good monitoring indicator to define nutritional status? So this albumin, like I said just now, is the most common phenomena that clinicians relate, meaning clinicians use serum albumin level to relate to one's nutritional status. However, albumin is non-specific inflammatory marker and has a half-life of about 21 days. Its low level is simply suggesting of inflammation, and the most sensible way to look at this is that you have to find the cause of inflammation and treat it. Once corrected, the albumin level will correspondingly normalize. And second of all, it is advisable to correct electrolyte abnormalities if the patient has already experienced it prior to initiation of the parenteral nutrition. Yes, you have to correct the electrolyte imbalance before initiation of any nutritional therapy to avoid the possible refeeding syndrome, like I said just now. Third is that what should you do when liver enzymes are steadily rising when a patient is on TPN? You have to make sure that the range LFT is not caused by the disease or inflammation itself. And then energy provision is from dual source, carbohydrate also lipid, and not from the glucose only. And we have to ensure, we have to eliminate the unaccounted glucose on board, such as IV dextrose, and reevaluate the total calorie requirement as the patient might be overfed. And lastly, how should we give TPN to patients with renal failure who are undergoing dialysis? We can use a more dense peripheral nutrition formula for these patients. So in terms of my take-home messages, so patients going for surgery will undergo major metabolic changes, which means that maintaining adequate nutrients is vital. You have to assess nutrition because nutritional status, because it is not a one-off process. The nutritional status of patients are dynamic and must be reviewed daily, and this plays an important ERAS plays an important role in enhanced recovery programs that can improve patient total outcomes. So that's about it in terms of basic of nutrition. So if there's no question, I'll proceed with my second presenter.